I've been a physician for over 40 years, and there has never been a year when there wasn't some sort of drug abuse problem. It seems like just when we get one problem under control, another drug appears. LSD, cocaine, methamphetamine, quaaludes, marijuana, heroin, prescription narcotics, and many, many more. And underlying all of that is a persistently high rate of alcohol abuse. It may be tempting to throw up one's hands and admit defeat, but we can't afford to do that. We have been successful in multiple areas, and we're learning more every year about what works. And given the creativity and persistence of the drug purveyors, we need to continue to work on preventing drug abuse, otherwise we'll have an even worse situation than we have today. Because of its importance on the health of our society, we'll be focusing on drug abuse trends and treatments on today's episode of A Public Health Journal. Please stay tuned.
Welcome to A Public Health Journal, a program that explores public health issues facing our society today and tomorrow. The host of the show is Dr. Ed Ellinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health and the Hennepin County Human Services and Public Health Department, all working together towards the goal of healthy people living in healthy communities.
Welcome to A Public Health Journal. Today we're going to be looking at the drug scene in Minnesota. We'll be looking at the use and abuse of both legal and illegal drugs and talking about what changes are occurring. In particular, we'll be focusing on prescription drug abuse, which has become an increasingly vexing problem. Joining me in that discussion is Carol Falkowski, CEO of Drug Abuse Dialogues, an educational and training program focusing on drug abuse. Ms. Falkowski has monitored drug use for over 30 years and has provided consultation on drug use monitoring and prevention to numerous federal, state, and local organizations. Carol, welcome to our program.
Thanks.
And so I started out by saying there's been a drug abuse problem every year that I've been in clinical practice and in public health and medical care. Is that true?
Oh, absolutely. People take drugs, and I think that's what people wonder in the first place. Why do people even take these drugs? People take drugs to feel good or to feel better. So in that sense, there's a broad appeal for drugs because drugs actually do deliver.
Yeah. So what's the downside?
Well, the downside of drugs is that you can become addicted and develop the disease of addiction, which is a chronic disease with behavioral components that really requires lifelong management and periodic professional services. You can deal with it, but you're never really cured of it. You have to manage it your whole life, like high blood pressure or diabetes or asthma.
Mm-hmm. But what are the trends? I mean, why isn't it always the same drug that's always popular? If it's to try to feel good, aren't the same drugs useful? Or why do we have some years it's opioids and some years it's quaaludes and some years it's meth that seems to rise to the top of our interest level?
Well, parallel with that is the enormous underground illegal business of drugs, which is hugely profitable. And there are changes in that marketplace, changes in distribution, changes in manufacturing of drugs. So now with heroin, for example, we have heroin that's being manufactured and in Colombia and being distributed through Mexico, much like cocaine was 20 years ago, being distributed through Mexico, but manufactured in Colombia. So the market forces have an enormous influence on what drugs are available as well.
Yeah, and you talked about addiction, and I've got a couple of slides here that I want us to talk about that show really the far end of the spectrum, actually drug deaths. So we have a slide here that shows drug deaths in the United States. And so explain what we're seeing on this slide.
Well, this looks at, the top line is looking at deaths from opioid analgesics or painkillers, prescription painkillers. And then the bottom line is looking at the number of deaths due to heroin. Heroin deaths have, and both of these, that just goes from 2000 to 2013, have increased enormously, both nationwide and in Minnesota.
So these are both narcotics, right?
Yeah, very strong opiate drugs.
Okay, and so we're seeing an increase. It looks like opioid prescription drugs are going up first, and then the heroin is following. What's the interaction between these two?
Well, both heroin and opiates work in the brain in the same way. They relieve pain, and they take you to that happy place. So they produce a euphoria. Many people, because we have so many prescriptions of narcotics and painkillers, many people who start using them inadvertently develop an addiction to them. And once that happens, they switch to heroin because heroin is so available, unlike it's ever been, and it's more affordable. So we see that connection. These two epidemics really go hand in hand.
All right,
with
and
each
we'll have
other.
a slide a little bit later, but the next slide I show really shows Minnesota drug deaths compared to traffic fatalities. And there's something really striking about this.
Right. For many decades, traffic fatalities and traffic deaths were the leading cause of death here as well as all over the country. But in recent years, the number of deaths from opiate drugs have exceeded those, and this is really unprecedented.
So traffic fatalities due to drugs or traffic fatalities are less than drug fatalities, so that when you put them in perspective, we really need to be focusing on drug
absolutely.
abuse.
And it's not just that the number of people are driving safer and cars are better and all that stuff. It really has to do with this enormous increase in people dying from prescription painkillers and heroin.
Okay, and that brings us to the last slide that I have here, and it really does show opioid prescriptions and show us what's going on, because this is going to be sort of what we're going to be talking about here for a little bit, about prescription drug leading to heroin use.
Yeah, this goes from 1991 to 2013, and the blue line are the total number of prescriptions for painkillers in the United States. Look at that significant increase, and in fact, in any given year now, there are enough painkillers prescribed legitimately in this country to medicate every adult 24/7 for a month. That's what we're talking about in terms of just the supply and the legitimate prescribing of prescription painkillers.
Yeah. So why, you talked, why do people use drugs? To feel better. And physicians have always, and providers have always been able to write prescriptions for pain drugs. Why has the number of prescriptions increased so dramatically? Have we taken a different approach to pain management in this country?
Well, for many years, the United States was historically accused of under-treating pain. And now we may have flipped to the other end where perhaps we are over-treating it. There are an estimated 100 million people in this country who suffer from chronic pain. We only have 320 million people in the country, so that 100 million people have chronic pain, which is non-cancer pain that lasts more than 90 days, is a pretty significant portion of that. So, and physicians are trained as the first line of defense in treating pain is to prescribe opioids. Well, now we're finding, the more people are looking into it, is that perhaps that's not the most effective first response, and that sometimes people, when they're on opioids for a long period of time, have such diminished functionality and such a diminished quality of life that perhaps from the get-go other things should be looked at or other changes could be made than just right away getting them on pain medication. So that's one thing. In addition to that, what's contributed to it is the direct-to-consumer advertising of prescription drugs, where everybody thinks, there's a pill for whatever ails you. And another contributing factor is how we emphasize the pain levels. When you go to the doctor, with the happy faces, what's your level of pain from 0 to 10, and maybe an expectation that no matter what is wrong with you, you can get that 0 pain, and that could be unrealistic as well.
Yeah, because that certainly has been a change in practice. It's sort of one of the vital signs is what's your level of pain.
Yeah, the fifth vital sign, yeah.
And that, I assume, did that come temporarily? I mean, at the same time?
Yeah, it was like the perfect storm. We had the direct-to-consumer advertising, the pain scale is the fifth vital sign, and doctors really being trained to just go with the prescription narcotics. I had the occasion to travel around the state and talk with many doctors on this specific topic. And I asked them, what did you learn in medical school about the addictiveness of prescription pain medication? And many of them said, well, they learned when they were in medical school, just prescribe it for pain. That's the most effective treatment for pain. And don't worry about addiction, because it just doesn't happen that often. It's a very rare occurrence. Well, now there have been a variety of different studies that look at that and what is the percentage of people who on pain medication will become addicted. And for some of the studies, it's up to, 25%. So we're learning more about it. And as time goes by, more and more people have been prescribed these things, and many of them sadly do develop an addiction.
Yeah. Well, I want to talk about the survey that you do on a regular basis and sort of what the trends in drug use are, but we need to take a little break first. We'll be back right after this comment.
When I was 6, my days were spent playing basketball. When I was 6, my dream was to make it to the NBA. When I was 6, my mom had a stroke.
I'm Paul George, and I want you to spot a stroke fast.
F, face drooping. A, arm weakness. S, speech difficulty. T, time to call 911. Protect the ones you love. Spot a stroke fast.
Welcome back. We're talking about drug abuse with Carol Falkowski, CEO of Drug Abuse Dialogues. Carol, you do this survey and you've been doing it for 30 years, collecting information from ERs and hospitals and following trends. What are we seeing here in 2015 about drug use in the Twin Cities and Minnesota?
Well, there are a couple of things. Having done this report twice a year for that many years, what really sticks out this time is that there's been a significant increase in methamphetamine in the Twin Cities, as well as the state of Minnesota, and we're approaching the levels of methamphetamine that we saw back in '05 when we were at the peak of the methamphetamine epidemic. And if there is some good news regarding opiates is that we have seen a decline in the deaths related to prescription painkillers in Hennepin County, but not Ramsey County, and this is all good news.
All right, so let's talk about meth. So we had a huge, people were cooking meth, and we had meth houses, and it was a huge problem and a lot of intervention. We banned the sale of over-the-counter pseudoephedrine, put it behind the counter, and that seemed to have some impact. Why is it starting to spike now? Well,
unlike it was 10 years ago, methamphetamine now is produced largely in Mexico, and the amounts of methamphetamine entering this country are enormous. The purity is very high and the cost is very low. So the supply is there, and as the result of that, more and more people are using methamphetamine again. And it's not just in the Twin Cities that they're approaching the same levels they were 10 years ago. Texas reports this, San Diego, Atlanta. There are other cities in the country are also seeing this resurgence of methamphetamine.
Mm-hmm. Which raises the question, are there drug trends nationwide, or are there pockets of different drugs that are trending in different places?
There are drugs that go on, it's very regional and local. And I remember Barry McCaffrey, who is the original, or one of the original directors of the National Office of Drug Control Policy, said, we don't have one single drug epidemic in this country. We have many drug epidemics, and they're driven by the nature of the communities in which they occur. And that's really true. I mean, there are some communities that have never been under the grip of methamphetamine. There are some communities that have never felt the impact of heroin to the extent that other communities do. There is variation, but still we are looking at a country where it's no longer limited to any geographic location. It's not just an inner city problem. It's all over the country to some extent, and really no community is immune from the lure and the problems associated with drug abuse.
Does Minnesota have some connection to specific foreign countries for the importation of drugs? I mean, you mentioned Mexico for meth. Is that sort of the connection here, and other states may have different connections to other countries?
Well, the drug business is so well organized and so lucrative. And I think we need to remember in Minnesota that we are just at the, what starts up at Grand Marais, Highway 35 goes all the way down to the Mexican border. And if people get instructed to cross the border and just obey all the speed laws and, don't draw attention to yourself, there's a pipeline, absolutely, that goes right up Highway 35. And the amount of trafficking of drugs along it is enormous. The seizures of methamphetamine at the U.S.-Mexican border by law enforcement between 2009 and 2014, the seizures of methamphetamine quintupled, and the seizures of heroin tripled. So this influx of drugs is at levels we have never before seen in this country, and as a result, more and more people are using the drugs.
So are the interventions that we did 10 years ago for methamphetamine, are we doing the same kinds of things now as law enforcement and drug abuse folks using the same techniques, or do we have to do things differently now?
Well, I think compared with 10 years ago, law enforcement is at an advantage because they don't have to be drawn away from doing, law enforcement and getting the bad guys and getting the big-scale drug dealers. They don't need to get distracted from that by shutting down these very small and very toxic and environmentally damaging methamphetamine labs. We really have seen a reduction in those small labs. But at the same time, the same very organized criminal networks that distribute heroin and have distributed cocaine are now distributing methamphetamine. So it's different, but it still needs to be very concerted effort by law enforcement.
Now you've said that there's been a slight decline in opioid deaths. What's attributable to that? I know we have a law that just got passed that you can have naloxone, where you inject this anti-narcotic drug and keep people from dying of an overdose. Does that have some role to play in this?
Well, absolutely. Naloxone is like an antidote for an opiate overdose. So if someone is in an overdose situation, they get a shot of this or a little squirt up their nose, and it just reverses it like an EpiPen does for bee stings. Hennepin County was one of the first counties to really institute that aggressively across the county, and I think that's a contributing factor. Another contributing factor to this decline in deaths in Hennepin County from opiates, I believe, has to do with the more aggressive prosecution we've seen of heroin cases by the U.S. Attorney. The number of cases of heroin and prescription opiates that have been prosecuted recently is much greater than it was just several years ago due to those efforts, and I think both of those things are making a difference.
So is there a different level of prosecution in Ramsey and Hennepin County for opioids, or they take the same approach?
Well, I think that many of the cases have been, the U.S. Attorney serves the whole area, but I think many of the cases have been people's over in Hennepin County.
Okay, and for the naloxone, who has access to that, the injectable?
It was really a law that was initiated by Senator Chris Eaton and Sheriff Rick Stanek, and it's available to people who are first responders. It's available to people who may have a loved one who is struggling, and the mother and father of a child who they found unconscious and in an overdose situation. Now the parents can get this naloxone, and it's really a lifesaver. If they administer it, their next action is to call 911, and it has saved lives all over the country.
So are the drug abuse education people talking about, not only here's how you intervene and here's how you prevent it, but here's how you get access to the naloxone, so people really know about this?
Yeah, I think so. And that is so critical. Another contributing factor is that unlike many other states, what distinguishes the state of Minnesota is that we have treatment available, addiction treatment, to a greater extent and with less of a weight than many other places in the country. So even as we have seen more and more people become addicted to prescription opiates, and methamphetamine, I mean, we have access to treatment to a greater extent than many other places in the country. But to tell you how big this opiate thing is, at the turn of the century, maybe less than 5% of people coming into treatment in the Twin Cities were there for prescription opiates or heroin, less than 5%. And now a quarter of the people coming into treatment are there for those drugs. So there's been an enormous change.
All right, well, I want to talk a little bit more about that, but first we need to take another little break. We'll be back right after this message.
Hart, what's going on?
I'm leaving.
Why? What did I do?
Not enough. You constantly ignore me. You barely eat anything healthy. You're half as active as you used to be. The pressure is just too much. I quit.
Okay, I get it. I'll do better. Just please,
Don't leave. Okay. But remember, if I go, you go.
Listen to your heart. Don't let it quit on you. Uncontrolled high blood pressure could lead to stroke, heart attack, or death. Get yours to a healthy range before it's too late.
Welcome back. We're talking about drug abuse in Minnesota with Carol Falkowski, CEO of Drug Abuse Dialogues. Carol, let's go into a little bit more detail about the prescription drug abuse. It seems like that is sort of the, from the slides we showed, as prescription drug use went up, heroin use went up, deaths are going up. We talked a little bit about what's behind it in terms of the pain scale and the marketing and doctors thinking of that. How do we address that complex issue?
Well, it is a complex issue, and with any drug epidemic, there are really some standard prongs to the approach. One is education, one is law enforcement, and one is having available treatment. But when we're talking about the prescription opioid crisis, we also have to look at the very practice of medicine and what changes can be made and how medicine is administered and how medicine addresses people with chronic pain, all 100 million of them. And so some of the things that are being developed are really advancing the science in terms of what is effective for chronic pain. And that whatever the findings from that come up with, that has to be incorporated into medical education and the practice of medicine. There are many doctors now going through medical school that get really only a handful of hours of formal training about what addiction is, and yet they're the ones who are writing the prescriptions that are so highly addictive, the painkillers. So we need to change education of doctors is really key to turning the tide on this.
Yeah, but also a lot of it is drug diversion also, isn't it? I mean, particularly for adolescents, using, physicians often write a 30-day supply of pain medicine, and the person, the adult to whom they had the prescription may need a day of it.
Right.
And then the other drug hangs around, and people then use it for diversion. Is that part of the issue, particularly for adolescents?
Oh yeah, absolutely. And maybe it's time that we also look at direct-to-consumer advertising of prescription drugs. It all started in the late 1990s, and since that time we've seen an enormous increase in prescription drug abuse. So maybe we need to look at all of these things. And just prescribing of narcotics, I'm so glad you mentioned that, because especially with sports injuries of kids, maybe it's take some ibuprofen and ice it and come back in a few days if it's not feeling significantly better, as opposed to, well, here's some oxycodone or here's some Vicodin and here's a 30-day supply, take as much as you need. I mean, those are the simple kind of changes that can be made in medical practice.
Now we have a prescription drug monitoring program, where the pharmacies and the physician groups are actually monitoring what drugs are being used. Is that helping?
Yes, all 50 states, with the exception of Missouri, have a prescription monitoring program. And that is really to reduce the practice of doctor shopping. People who feign pain and pretend that they have pain and go to multiple doctors to get prescriptions of painkillers. That's an effective tool in reducing that practice of doctor shopping. Still, as with any systematic change, there's room for improvement there. But overall, those are really a step in the right direction in reversing this problem.
Can it be also used to monitor physicians to see who might be overusing prescription drugs in terms of prescribing practices?
Yeah, yes, it can be. But that becomes more complicated because there's some doctors who by definition are treating pain patients, and so you have to take that into account as well, their type of practice.
All right. And certainly we can't get beyond this conversation without talking at least about alcohol a little bit. I mean, alcohol continues to be one of those drugs of abuse that overwhelms everything else, I suspect.
Yes, and for many parents, they think with all these other drugs capturing the headlines to such an extent, they think, well, if their child or adolescent drinks alcohol, it's just alcohol. Well, that's an unfortunate misperception. There has been great inroads made in reducing underage drinking, absolutely. But alcohol still accounts for about half of the people coming into treatment here as well as nationally. And all drug addiction is really adolescent onset disease. So we need to still be very mindful that alcohol is an addictive drug, and people put them, and we know, regardless of what the specific drug is, that the earlier the age of onset, the more likely the development of addiction. So the earlier kids use drugs or alcohol, not only are they putting themselves at risk for all the stupid things you do when you're under the influence and have impaired judgment, but you're also putting yourself at heightened risk for a lifetime of addiction. The earlier the age of onset, the more likely the development of addiction. So we can't forget about alcohol in that.
All right, so if I hear these numbers, so people into treatment, half of them are there because of alcohol, 25% are there because of prescription drug addiction. And what are the other 25%? A whole array of things?
Yeah, cocaine is very small now. Cocaine has really declined. About 13% are there for methamphetamine, and then it's everything else.
Okay, and we only have
marijuana.
a couple minutes left. I mean, there's this big push nationally for legalizing marijuana. What's the conversation in the drug abuse community around the legalization of marijuana? What are the questions that need to be asked? What do the policymakers need to consider in state by state if they're really looking at whether or not they should legalize marijuana?
Well, the conversation within people in the addiction field is one of great caution, because people in the addiction field see the downside, and people who at very young ages become addicted to marijuana. It is an addictive drug. We also see the emerging science that shows that early onset marijuana use and heavy adolescent marijuana use can result in cognitive decline that can last well into adulthood, that seems to be irreversible. So we need to be very concerned about that. At the same time, 23 states in Washington, D.C. have medical marijuana, 4 states have recreational marijuana, and in those states with recreational marijuana, they're having a lot of the consequences that were anticipated. You know, if it's legal, more people are using it, so they're seeing more adverse reactions on the highways, they're seeing more kids suspended, they're seeing more overdoses in emergency rooms from edible problems, kids getting into the edible products that are unlabeled to a large extent. So it is such a game changer. It is such a different world with marijuana. That could be the topic of a whole show.
Well, as I said in my introduction, this has been an ongoing conversation for 40 years that I've been in practice, and it'll be a continuing conversation, and we'll have you back again to talk about current drug trends a year from now. So, Carol, thanks for being with us.
Well, thank you.
And I'll be back with a closing comment right after this message.
Get caught buzz driving, and you could do some hard time.
Craig, knock it off.
Sorry, Mom.
It could cost you around $10,000 in fines, legal fees, and increased insurance rates. And that could set you back a few years. Buzzed, busted, and broke. Because buzz driving is drunk driving.
One of our biggest concerns is about drug use by adolescents, because adolescence is that crucial time of transition from the dependence of childhood to the independence of adulthood, when lifestyle choices about alcohol, tobacco, and other drugs are being made that will have a lifelong impact. Although today's adolescents are very skilled in many areas, most aren't yet ready to independently take on all these choices and decisions. They need some assistance. They need some advice, direction, and even some limit setting from adults. But in particular, they need some role modeling. They need to have examples of how to face the challenges of social pressure, the appeal of immediate gratification, and the glitz of product marketing, and still make decisions that are health enhancing. It is our responsibility to provide that role modeling. As adults, we have the responsibility to guide adolescents toward eventual independence, to teach them how to make decisions that keep themselves safe and healthy, and to help them become contributing members to our society. This is a responsibility and a duty that we must take very seriously. It is our contribution to the short-term and long-term health of our society. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.